Background of the GAIA or CL13 study is that venetoclax, the BCL2 inhibitor in combination with obinutzumab, given for 12 months of treatment as a targeted time-limited treatment regimen, is approved in all CLL patients. But in fact, the approval study, the CL14 trial, was done only in unfit CLL patients. Therefore, the question was still open. What about the comparison of venetoclax-obinutuzumab versus these more intensive chemoimmunotherapy regimen we used so far in CLL as fludarabine cyclophosphamide rituximab or bendamustine rituximab? Though that was the one question, because the study has two co-primary endpoints. The second question is, what about intensification of this combination when we add the BTK inhibitor ibrutnib? And therefore, we also wanted to evaluate a triple combination in comparison to chemoimmunotherapy with respect to efficacy, but also with respect to safety. Yeah, this was a phase 3 study with 4 different treatment arms. And we did a central screening in the study in order to exclude patients with TP53 mutation or deletion 17p, because we had the chemoimmunotherapy arm, and we did that by central screening. And patients were stratified due to age, because in the chemoimmunotherapy arm, the patients up to the age of 65 years received FCR, and elderly patients received bendamustine rituximab. And then there was a 1-to-1-to-1 randomization between all 4 different treatment arms, which contained, as mentioned, venetoclax plus obinutzumab, venetoclax plus obinutzumab plus ibrutnib, and there was another arm containing venetoclax plus rituximab, because we also wanted to address the question, what is the influence of the CD20 antibody? We had with the 2 co-primary endpoints. One of them was the rate of undetectable MRD. We analyzed that already last year, and data were presented at ASH 2022. We found higher rates of undetectable MRD rate of venetoclax-obinutuzumab, but also with the addition of ibrutinib in comparison to chemotherapy. And what I presented here at the late-breaking abstract session is that also the interim progression-free analysis, interim progression-free survival analysis after more than 3 years shows a superiority. Now, with respect to our radical testing for statistics, we tested first the triple combination, venetoclax-obinutuzumab, ibrutinib, clearly superior risk reduction for relapse by 65%, and also the venetoclax-obinutuzumab combination is doing a risk reduction by more than 60%. So it gives, on the one hand, confidence that this is an excellent treatment option in patients in frontline when they are younger, so confirming the approval status. And it also helps balancing the decision, particularly in patients with less favorable genetic profile. These are, for example, patients with an unmutated IGVH status, where the alternative treatment would be continuous treatment with a BTK inhibitor. And therefore, these data are very helpful in the daily practice to inform your patient what is the expected PFS with venetoclax-obinutuzumab and ibrutinib, which is quite similar, but you have time off with the venetoclax-obinutuzumab regimen. I would not yet use the triple regimen. It's not approved, this triple combination. And I think we also need here further follow-up in order to see what is really the benefit of this regimen, because we have seen some more toxicity, particularly more infections in comparison to the double combination with venetoclax plus obinutzumab.